Hello, everybody. Let's get this Module 3 review started. So we're going to go to your Module 3. All right, skip on down to the bottom of this Module 3, where we get our Exam 3 review, and that is what we're going over today, plus a couple extra things. Okay, so first off, I want to start with, as we're getting ready to take our Module 3 exam, everybody needs to be completed with all of their chapters, all of their Module 3 chapters. Everything that's on the calendar and on the due date in your Canvas needs to be up to date. That blue emergency chart needs to be completed. Remember, your blue emergency chart and half of your green emergency chart cover your traumatic emergencies. And make sure you have that Module 3 group quiz done as well. Okay. So let's go ahead and get started on this exam review. Okay, so the first couple of things, it just jumps right into signs and symptoms of some very specific traumatic emergencies. Traumatic asphyxia. This one is pretty straightforward. This is going to be a chest injury, and we get this when the chest has a sudden compression on it. Okay, and hang on, let me pull this up. So it's a sudden and severe compression of the chest, and that compression causes a very rapid increase in the intrathoracic pressures. Because of that increase in pressure, the blood actually is going to backflow out of the right ventricle of the heart into the upper body. So, excuse me, the blood is actually going to go backwards instead of forwards because of that compression. And so the signs and symptoms that you would see in a patient experiencing this would be distended neck veins. Their eyes will actually have like a bulging bloodshot appearance. From the nipple line up in their chest, they'll have a cyanotic appearance to their skin, dark cyanotic appearance. And their tongue will also be swollen because, yet again, like I said, they have that backup of blood into their upper body from that severe compression on their chest. This is going to be when someone is caught between, two surfaces, and they're basically pinned between two surfaces at the level of their chest. The treatment for that is really ABC management. There's really nothing that we can do for the compression itself other than call for additional resources. If they're still pinned, we have to call for additional resources to extricate the patient from whatever that is that they're stuck in, and then be ready to aggressively maintain and manage our airway, breathing, circulation, possibly do some bleeding control, and put, occlusive bandages if there's holes in the chest. There's multiple things that you would have to do, but there's no fixing that. That is a rapid transport to the hospital while we're managing the life threats. Your next one on this list is subcutaneous emphysema. And subcutaneous emphysema is a condition when air gets underneath the surface of the skin. And this can happen from penetrating injuries. It can happen from injuries that perforate our airway structures. But it's basically air that gets underneath the outer surfaces of the skin. Basically, it's not like a pneumothorax. This isn't in the pleural space or anything like that. This is actually in the dermis. So the best way for me to explain this is like think about when you're trying to put a cover on your phone or on your iPad Surface or something like that. And if you ever get like an air bubble underneath it. That's kind of what this is. And it can be very painful to your patient. And if there's enough of it, maybe like in the neck area and stuff like that, then it can, cause pressures to their trachea, and we might need to be careful of that. But it's very painful to the patient, and is really just something to be aware of. Again, there's not any kind of technique or method for us to get rid of that. We just need to take them to the hospital, a trauma center for that while we manage our ABCs. Next on the list is the flail chest. Flail chest is another emergency that occurs to the chest, right? Obviously, it's a flail chest. So what is it? First off, a flail chest is when we have two or more adjacent ribs that are fractured in two or more places. So two or more adjacent ribs. So adjacent means next to one another, right? So we have a couple of ribs next to one another that are broken in two or more places. And basically that area or that section of the rib is actually completely detached from the rest of the rib cage. The way that the break is and the pattern of the break is it's completely detached from the remainder of the rib cage. And because of that, it will move opposite to the normal movements of the rib cage during your patient's breathing. And we call that paradoxical movement. So when you have paradoxical movement, it's gonna be opposite to the normal. So think about when you breathe in, when you take a deep breath and your chest expands, okay, your rib cage goes up and out. And if you had a flail segment from a flail chest injury, then that segment will not go up and out. It'll actually depress and go in. So it's going to do opposite. And then when you exhale, and normal exhalation will bring your rib cage back in, right? It'll kind of deflate. That flail segment will actually pop out. So it's got opposite movement, or what we call paradoxical movement, to the rest of the chest. That movement actually inhibits and interferes with the normal breathing of your patient. So the treatment for a flail chest is to provide positive pressure ventilations and supplemental O2. Okay, and positive pressure ventilations, remember, is when we use our BVM. So again, airway, breathing, and circulation. Remember, in trauma patients, our priorities are always X, ABCs. The X stands for exsanguination, so you need to deal with any uncontrolled bleeding first, and then airway, breathing, and circulation. So make sure that if there's any uncontrolled bleeding, you take care of that. And then for that flail chest patient, you start to bag them and just help them breathe. You would breathe with their normal respiratory rate, just kind of help them breathe. Your next thing on here is the tension pneumothorax. And tension pneumothorax, we have talked about before in module 1, because the tension pneumothorax is an example of obstructive shock, or something that causes obstructive shock. And remember, obstructive shock is the obstruction of the forward movement of blood flow, right? So in a tension pneumothorax, we have that accumulation of air in the pleural space. And actually, let me back up a little bit. I want to go back to the flail chest, because I always like to show you guys a YouTube of flail chest. Okay. So just a little something so you can see. Where did it go? What is this one? Okay, that's pretty horrific. You can kind of see how the chest is going in, in segments where it's supposed to be going out. It's opposite. This is another really good one. Okay. So of course, you wouldn't see that unless you take the, you expose your patient, right? So when we talk about using our trauma shears and cutting the clothes off and really looking at your patient just to make sure we're not missing anything, It's super important. You have to do that head to toe. They may not even have a complaint. What if they're unconscious? Then you have to find the problems. So that's what that paradoxical movement looks like for your flail chest. So going back to your tension pneumo, let's keep talking about that. Your tension pneumo, like I said before, is this is the accumulation of air in the pleural space. And if you remember, the pleural space is that space around the lung, right? It's in between well, here, let me just see if I can pull it up for you. All right. Here's that pleural space. Okay. So that's where that is. So that air is accumulating in that pleural space. And remember, as that air accumulates, then it's going to collapse this lung, which is where we get the term pneumothorax. It collapses the lung. And then this middle section right here is the mediastinum. This is where the heart sits, right? So let me get you a picture of where the heart is. Sounds good. And we'll go over all these. But this is what we're looking at. This is the mediastinum, and it is now pushed or compressed, in the opposite direction. So whether it's inspiration or expiration, it doesn't matter. But as that air is accumulating, it builds up and it shifts the heart. It compresses and shifts the heart. And then it also compresses on the opposite lung, right? So your patient is not only going to have complaints of shortness of breath, but other signs and symptoms would be on the affected side, on the side where there is the pneumothorax. It's going to be diminished or absent breath sounds, depending upon how much air is still moving within this lung. And then your patient, like I said, is going to have a complaint of shortness of breath, probably pain in the chest from whatever injury caused it. And we'll talk about that in just a moment. But and then because it is compressing on this heart, and we know that a tension pneumo is a cause of obstructive shock, you really need to watch your vitals, right? Think about that compensated shock, the first phase where we see tachycardia and normal blood pressures, and then decompensated shock, which is the later phase of shock where your patient is still tachycardic, but is now developing that hypotension, right? The blood pressure is now dropping because despite the efforts of the heart, they're no longer able to compensate for this problem and they cannot maintain the perfusion, right? So those are the kinds of signs and symptoms that you're going to see with your patient that has a tension pneumo. You might also see that tracheal shift. So when we're going down and doing that focused head to toe, when we get to the neck, not only are we feeling the cervical spine on the back of the neck and making sure there's no injuries there, but we're looking at the front of the neck, right? And we're looking at the trachea to make sure it is what we call midline. So it's straight and still in the middle of the throat, right? And then we also look at our JVD, our jugular veins, and we're looking for JVD or jugular vein distension. Distension is when they are expanded and swollen. Okay, so I'll make sure and show a picture of that to you guys as well. So we don't want JVD and we don't want tracheal shift. We want a midline trachea and flat jugular veins, right? That's what we want. But if you start to see the JVD and other things, plus your patient has an injury to their chest and shortness of breath and other problems, right? Diminished lung sounds on one side, then all of that stuff is pointing towards a pneumothorax. Okay. So while we're here, let's just go over closed versus open. And I know I've already kind of discussed this in some classes. I think it was in the academy class, but we'll make sure and touch upon this in the others before we take our test. So you have an open pneumothorax, you have a closed pneumothorax, and then you also have what's called a spontaneous pneumothorax. And those three things all can occur at some point based upon different mechanisms, which we'll discuss in a moment. But any one of those can lead to a tension pneumothorax. Okay, so a tension pneumothorax is not something that it's not something that starts on its own, right? This is something that actually develops. So if you have an open pneumothorax, and an open pneumothorax is something that has an injury to the chest wall, okay? So there's an injury to the chest wall, whether it's a GSW from a gunshot wound, it's a stabbing, or it's some kind of other penetrating wound. There is a hole in the chest, okay? And we worry about this because that means that air from the outside environment can come in. All right. Now you could have a shallow open pneumothorax where it did not puncture the lung and you only have air coming in from this way, or you could have a deep pneumothorax, or a deep, I guess it's not a pneumo, but a deep mechanism that has punctured the lung as well. So not only do I have air coming in from the outside, but I also have air escaping from the lung into this pleural space. So it can kind of grow faster. Okay, kind of think of it that way. The first thing that I want to do to manage an open pneumothorax, or to manage that hole in the patient's chest, is to place my gloved hand over it. That's what I want to do. I want to place my gloved hand over it and basically cover up the hole. That's what I want to do. I want to cover up the hole as soon as possible to make sure that air doesn't continue to go in to that pleural space from outside. So I'm going to take my gloved hand and place it over the hole. It doesn't matter if it's bleeding or not. I'm going to put my hand over it. Okay. And then we're going to go get an occlusive dressing, right? I'm going to have my partner or someone else is going to have an occlusive dressing, and we're going to place that. Now, an occlusive dressing, and I may be getting ahead of myself, but since we're already talking about tension pneumos, let's just go ahead and talk about this stuff. An occlusive dressing, excuse me, is something that is your best management of that pneumothorax, of that open hole, okay? You can also think of it as, we call it a sucking chest wound, okay? So those are kind of, an open chest wall injury or a sucking chest wound, those are kind of interchangeable, okay? Open, there we go. So what you want is you want this occlusive dressing to be on your patient in a way that it's going to make sure that the air does not go in, but it still has a part where the air can vent out from the hole. Okay, so when we talk about occlusive dressings, if you have to put one on yourself, and it's basically you can get just a piece of plastic, and we'll talk about that. Think about it. Your nasal cannula comes in a plastic bag. Your non-rebreather does. Your anything that you have on your box, just open it up and use the plastic. Stick it on the wound and tape it on 3 of the 4 sides. Don't completely tape it, because if you tape it completely around, then it won't be able to vent, right? And if there's any air accumulation in that pleural space, then it won't be able to come out. And that's the whole purpose of this occlusive dressing, is to have it taped on 3 of the 4 sides, okay? And this is kind of like 3.5, but it still has a place for it to vent. So the air cannot get in, but it does allow the air to escape, okay? Now you can have the one that you made yourself with the plastic and the tape, or you can have actual chest seals that you can purchase that have, it's pretty simple. It looks like has, again, tape on 3.5 of the sides, and this is kind of open. You can have other ones, and it just really depends upon what your agency carries. You can have other ones. These are kind of some of the ones I've seen before that have little vents on them, right? Or a little area. There's multiple ones, but you place it over the wound and you make sure, see, here's your vent channel. You make sure that it still has that channel open, or that little vent open. Okay. All right. So going back to this. So that was your open pneumo, right? So gloved hand on top, place your occlusive dressing, make sure that it can still vent, because if it cannot vent, then this air will accumulate and build up, and it will turn into a tension pneumo, okay? A closed pneumothorax is something that can occur most likely from like blunt trauma, because there is no hole in the chest. Okay, there's no hole in the chest wall. So the air itself is not coming from the outside. The air is coming from an injury to the lung. Okay, and if there's blunt trauma to the chest, and this can be anterior or posterior. Okay, so don't forget, the whole back part of the patient, is also the thoracic area. So it could be an injury to the front or the back. But if the injury is to the point where maybe it broke a rib or it broke something in there, and maybe the rib punctured their lung, or somehow the lung was damaged and is now leaking air into the pleural space, okay, that is still considered a pneumothorax, but it's a closed pneumothorax because the chest wall is intact, okay? So I'm still going to have air that escapes in here. And guess what? Signs and symptoms are going to be the exact same thing. Patient's going to be short of breath. They're going to have diminished lung sounds on the affected side. And they're going to have some kind of mechanism of injury, that had enough force to do something like this, right? So make sure you get a really good history of your patient. Now, this person, unfortunately, as an EMT, you can't manage this. There's nothing you can do to fix this except recognition and then rapid transport to the hospital, right? If it still continues to accumulate, then it can progress to a tension pneumo, and you need to watch your vitals and watch your patient. Excuse me, and make sure that we're not staying on scene very long and getting them going. The open pneumo you cannot fix, but you can manage with that chest seal, right? And if your patient does go unconscious, or if they are starting to have issues breathing, then you can assist their ventilations with the BVM. Make sure they have high flow O2, right? If you're not bagging your patient yet, put them on a non-rebreather with high flow O2. But this is definitely any kind of chest injury where your patient has shortness of breath. They need to be on high flow oxygen, flat out. That's just a given, okay? Do not put this patient on CPAP, okay? Because if your patient has a pneumothorax, then that is an absolute contraindication to CPAP. So we cannot place these patients on CPAP. Okay. So let's get back to here. So we talked about tension pneumo. We talked about the other ones above it. So now let's move on to ruptured diaphragm. So your ruptured diaphragm, first off, everybody remembers where your diaphragm is. It is the most inferior portion of your thoracic cavity and the most superior portion of your abdominal cavity, right? So well, let me just see if I can pull up a picture here. It's kind of the structure that separates our thoracic from our abdominal cavities. And what is this? What is this? No. Sorry, I'm looking at pictures here, seeing if there's something that's good. Okay, never mind. All right, so a ruptured diaphragm. So obviously ruptured means it's no longer intact, right? So if your diaphragm is no longer intact, and most of the time, well, it could be from either penetrating or blunt trauma. Blunt trauma, that's the mechanism is high enough to rupture the diaphragm. That's going to be a pretty large amount of energy transfer into the patient. But then you can also have a penetrating injury, right? And you got to think of angles, right? Think of your angles. Just because something comes in from one direction doesn't mean that it went straight through. Maybe it was angled at a downward or an upward angle. And so if your patient has a penetrating injury to the upper part of their abdomen, then it's very possible that whatever it is that went into them also broke through their diaphragm and went into their thoracic cavity, or vice versa, right? So if you have a ruptured diaphragm, or your diaphragm is no longer intact from some kind of mechanism, then basically you no longer have the separation of your thoracic and your abdominal cavities, and your organs and portions from each will mix together, okay? Now your lungs aren't going to be moving, and your heart obviously isn't going to be moving, but most of the time it's going to be your small intestines. Okay, so your intestines are actually going to shift from your abdominal cavity up into your thoracic cavity because they're no longer being contained in the abdominal cavity. So that ruptured diaphragm is going to, when you're listening to lung sounds and you hear bowel sounds in their thoracic cavity, then that is not so good, right? That is not a good thing. Oh, excuse me. If your patient has bruising or contusions, to their abdominal, to their abdomen, to the outside part of their abdomen. I'm just thinking about other signs and symptoms. Shortness of breath, because now their lungs may be having to share space in that thoracic cavity with the intestines that they normally don't have to. So take a look, take a listen. Can we fix that? No, we cannot fix that. That needs to go straight to a trauma center for surgery, right? So a lot of this trauma, if it's not a bleeding issue, the life threats are managed with just airway management, suctioning, bagging our patient, and doing that kind of stuff. Okay. A pulmonary contusion. So a pulmonary contusion, first off, remember a contusion means a bruise, right? And if you think of it, when you get a bruise on your arm or something like that, it's darker in color, and it's because you actually have some of your capillaries have ruptured at the surface of your skin because of the force of the contact, whatever it is that caused the bruise. So that's a contusion. And a pulmonary contusion is a bruise in the lungs. Okay, or a bruise of the lungs. And if you have capillaries that have burst within the lung, then you're not going to have very good gas exchange in those areas. Okay, so let me pull up a little picture here. Will kind of help illustrate it. And this is basically what it is. You can just kind of think of it as, a bruise to that area of the lung. Okay. And that area of the lung right there is not, like I said, it's not going to have as good of gas exchange as other parts that are unaffected. So they're going to have shortness of breath, probably going to have pain to the chest from the mechanism itself. Okay. So a little hemorrhaging in between, in and around the lung tissue that will affect the alveoli in that area. Okay. There's another picture I normally look at. This one. This one's pretty good. Here's your normal lung tissue. Okay, and all those little open spaces, that's where your gas exchange occurs. But the pulmonary contusion, those open spaces are kind of filled with blood from the small capillary bursts that occur. And so in that area, gas exchange is not good, right? So place your patient on high flow O2, get a good history of what's going on, and airway management, suction if needed, bag your patient if needed, and get them to the hospital, right? Rapid transport to the hospital. Let's see here. I'll let you look at some of those other pictures if you want. So, all right. Cardiac tamponade. Cardiac tamponade is another cause of obstructive shock. So we already talked about tension pneumothorax, which is a cause of obstructive shock. Cardiac tamponade is another one. Cardiac tamponade, if you remember from Module 1, this is where we have some kind of fluid in that pericardial sac around the heart, okay? And that pericardial sac that sits around the heart, if there's fluid within it, then that fluid's not going anywhere, and it's compressing the heart, and it's keeping it from filling with blood, and so it's reducing that preload. It's not filling with blood, and so therefore it's not able to have as much cardiac output as it normally does, which in turn is why your patient has shock from cardiac tamponade, low perfusion or shock, right? So with cardiac tamponade, though, not only is it important to understand the mechanism and the patho behind it, that it's an obstruction of the normal movements of the heart, but it's also important to recognize the signs and symptoms of it. Same as what we've been talking about with the previous emergencies. So cardiac tamponade is going to have some very specific signs and symptoms, and it's what we call Beck's triad. B as in boy, B-E-C-K, Beck, Beck's triad. Okay, and a triad, of course, is three things. And Beck's triad is going to be JVD, which is our jugular vein distension. It's going to be narrowing pulse pressures, which I'll talk about in a moment, and muffled heart sounds. So those three things are going to be like your telltale signs of cardiac tamponade. And cardiac tamponade can be caused from a penetrating injury, some kind of penetrating injury that goes in, and now there's bleeding around the heart, right? Could be blunt trauma. It also could be like an infection of the myocardium. If there's pus or other stuff around the heart, it doesn't have to be trauma, although trauma is normally like one of the main causes. Excuse me, it's more of a common cause, but there's a couple things that can cause cardiac tamponade. So Beck's triad, we said JVD, and I told you guys I was going to show you a picture. So let me show you a picture of JVD. Okay. So your jugular veins, which remember you have them on each side. Okay? Your jugular veins, these are distended. So you look at this and you go, yep, that's not supposed to be there, right? That vein is distended. It's plump. It's swollen underneath the surface of the skin. Normally we don't see that, right? Normally we don't see that. Look at this one right here. This is just crazy, right? It looks like there was something sewn underneath the surface of their skin, but that is definitely a lot of jugular vein distension, okay? Anytime you see that, that means that the blood is not moving forward, right? The blood is not moving forward, and you could see this with cardiac tamponade, like we're talking about. You can see it with tension pneumothorax. You can also see it with congestive heart failure if you have that right-sided involvement, where it's backing up into the body. So there's multiple things that can cause JVD. So not only recognizing it, but also knowing the mechanism and doing your assessment of the history of the events that may have caused this is important, okay? But JVD is one of Beck's triad. You also have your narrowing pulse pressures, okay? And I want you to think about your blood pressures, right? So when your heart is filling, then that's kind of what we call the relaxation phase of the heart. When it's contracting, that's the active, contraction part of the heart where it's forcing the blood out. So your systolic blood pressure comes from the contraction of the left ventricle. Your diastolic blood pressure comes from the relaxation phase of the left ventricle. And if you have a heart that is not able to fill very much, right? And think about that rubber band, if it's barely moving, then the pressures in one phase versus the other phase are so similar to one another that they're going to be very close together. So we talk about narrowing pulse pressures. That means that your systolic and your diastolic numbers are really close to one another, okay? Normally we have, blood pressures that are like 120 over 80, 130 over 85, 140 over 90. There's a pretty decent spread between your systolic and your diastolic, right? It's a pretty decent difference. This is where you're going to see those numbers get really close to one another, like 90 over 80, right? Or 92 over 84. Very, very close, abnormally close. Something that when you obtain your blood pressure and you're like, oh, it's not 92 over 80. You should be like, well, that's odd, right? That's odd. So we've got a mechanism of trauma to the chest, patients having a hard time. They're not feeling very good. I see some JVD. Wow, their blood pressure is like super close to one another. And then the third one of Beck's triad is the muffled heart tones. Okay. And so this little illustration right here is going to be muffled because it's not moving a whole lot. And it's also surrounded by fluid, right? It's surrounded by fluid. So you're not going to hear it very clearly if you happen to listen to that. And here's that pericardial sac, right? It's filling with volume. And so the heart inside cannot fill it on its own. And when it doesn't have that preload, then it has that decreased cardiac output, right? Makes sense? All that compression around the heart. So cardiac tamponade, some kind of, most likely some kind of injury to the chest, okay? Or, like I said before, it can be medical. So maybe history of infection, okay? History of infection. And we've got the Beck's triad, okay? JVD, muffled heart tones, and narrowing pulse pressures. A concussion is it's a form of a traumatic brain injury. Thankfully, it is temporary, which is nice. But your patient is going to have some kind of mechanism, of course, where they struck their head or their head was struck, right? They'll be complaining of dizziness, lightheadedness. Maybe they might be nauseated. They might be vomiting. They might have memory lapses. Okay, or they may be completely unconscious. But like I said, thankfully that concussion is most of the time it's a temporary thing, but we still need to take them to a trauma center. Okay, number 2, intracranial pressure. So intracranial pressure has specific signs and symptoms. Yes, it does. Okay. So we talked about Beck's triad with the pericardial tamponade, but now we're going to talk about Cushing's triad. Okay. And Cushing's triad, another 3 things. This is what deals with increasing intracranial pressure. So first and foremost, intracranial pressure, that's going to be the pressure that's within your head, inside your cranium, right? Or inside your skull. And we don't want those pressures to increase, because when those pressures increase, then that means that your brain functions are going to suffer. All right. Now, if you have a traumatic brain injury, whether it's a hematoma, epidural, subdural hematoma, or a brain bleed like a hemorrhagic stroke or a concussion, any of those things, right, are going to have Cushing's triad. And Cushing's triad is, I want you to remember that the vital signs, specifically the heart rate and the blood pressure, are opposite of shock. Because in shock, we have tachycardia and hypotension. But in Cushing's triad, we have hypertension and bradycardia. Okay? So Cushing's triad. Is increased blood pressure, specifically the systolic, and I'll talk about that in just a minute, okay? So Cushing's triad is going to be hypertension, or what we would call widening pulse pressures. So we talked about narrowing pulse pressures in Beck's triad. Cushing's triad is widening pulse pressures, and that's when the systolic and diastolic numbers are getting further away from one another, okay? So if you take a blood pressure and maybe it's 140/90, and then a couple minutes later you take it again and now it's 154/92. And so you see that systolic is spiking up, but the diastolic is staying the same. And then maybe, 5 minutes later, you cycle your blood pressure again because you're reassessing on this unstable patient. And now, instead of 152/90, then now it's like 170/92, right? So that systolic keeps creeping up, but your diastolic stays the same. And that's where we have that widening of the pulse pressures. So this little illustration right here, it says an increase in systolic BP, and that's true because it's hypertension, but it's only in the systolic. The diastolic stays normal, and that's where we get our widening pulse pressures. The pulse itself is bradycardia, right? So it's going to be a low pulse. And then the respirations are going to be irregular respirations, okay? Up or down, but irregular respirations. Anytime you see Cushing's triad, then that is an indication of increasing intracranial pressure, okay? Increasing intracranial pressure. And like we said before, that's with head injuries of epidural bleeds, subdural bleeds, concussions, hemorrhagic strokes. I can't think of anything else right now, but Cushing's triad. So really watch your vitals. One of the things we talk about when we're going over the tests after you've taken them is look at your vitals. What do your vitals tell you? Or at least I know I say that in class. What do your vitals show? Really look at those vitals. Those are really important. Okay. In trauma patients, if you have a patient who is bleeding and they have tachycardia and hypotension, then they're hypovolemic, right? They have a volume problem and they're in shock from volume. If they have some kind of mechanism where they may have struck their head and they're hypertensive and bradycardic, then that's Cushing's triad and they have increased intracranial pressure. And my focuses will shift. Okay, my focus will shift to airway and breathing and things like that, because at some point, if that brain continues to swell inside the cranium, it can't go anywhere else, right? You have to think about your skull it's a big old helmet, and it doesn't flex. It doesn't flex at all. So if your brain is swelling, whether it's swelling because of an injury direct to it, or it's having to share space with blood, like an epidural or subdural hematoma, which we'll talk about a little bit later in this review, then that skull doesn't flex, right? So where does the brain have to go? Increasing intracranial. Let me see if I can get you a good picture of this. Oh, excuse me. This is what I want you to see. I want you to think about the skull. Okay? It doesn't flex. And so if this brain is being displaced due to, like I said, is sharing space with blood from a bleed, then that brain is actually going to be pushed out of this hole down here where the spinal cord exits. What is that hole called? I know y'all know what that hole is called. Let's see here, cranium anatomy. Okay, so there's the skull, right? You got this hole down here at the bottom, and that's where the spinal cord comes out. That hole is the foramen magnum. That's the only place that brain has to go if it's swelling, right? It's the only place, and that's where you're going to start to see symptoms of brain herniation with decorticate and decerebrate posturing. Right? And decorticate and decerebrate posturing are things that you'll see on your Glasgow Coma scale. So make sure you just review that a little bit and make sure that you're aware of what that is. If your patient actually has a skull fracture, then I don't want to say that's not a bad thing, because it's still a bad thing, right? But excuse me, that allows, if there is swelling or some kind of injury to the brain, then it allows a little bit of flex, right? And if there's flex, then you're not necessarily going to see all of those Cushing's triad symptoms, okay? Because the pressures aren't increasing within the skull. So you're not always going to see Cushing's triad on head injuries. If there's, if there's skull fractures and stuff like that, then you may not see it, or you may not see it as pronounced. Okay. Let's get back to your exam. We're getting kind of off in the weeds here. Okay, so what is a basilar skull fracture, and what are some signs and symptoms that are expected? So a basilar skull fracture, first off, basilar, that means at the base, okay? So a basilar skull fracture is going to be where the force of the mechanism was such that it cracked or fractured the base of the skull, okay? And there's very specific signs that come off of this. You're going to see, okay, so we've got a fracture at the base, right? You're going to see what we call raccoon's eyes, okay? The more medical term is called periorbital ecchymosis, okay? And periorbital ecchymosis is this bruising around the eyes. You will also see what's called battle signs, which is bruising behind the ears. Okay, and then you're also going to see a halo sign, which I'll talk about in just a moment. But I'm not kidding. When they look like this, they look exactly like this. I've seen this on patients before. It looks like they've got two black eyes, but it has nothing to do with injury to the front part of their face. It has to do with the fact that they have a big old fracture in the base of their skull, and they'd also have some bruising behind their ears, and that's what we call battle signs. So the periorbital ecchymosis, or the raccoon's eyes, and the battle signs. And they will also have a halo sign, and this halo sign, if your patient is bleeding out of their ears, then we do the halo test, okay? And the halo test is you take a piece of gauze and you place it up to their ear, kind of let it soak in some of that blood, bring it off, and then if it has this ring around it, right? So here's the blood in the middle, but it has kind of this ring of lighter colored fluid. That right there is actually cerebrospinal fluid. And cerebrospinal fluid, the presence of CSF or cerebrospinal fluid tells us that we have a skull fracture. Okay, it tells us that we have that basilar skull fracture. Let's see here. Okay, so he's got bleeding coming out of his ears right here, and it looks like he may have been on his side, or maybe they took this and just kind of brought it up. But you see the blood in the middle and then the lighter color or halo around it. And that is an indication of cerebrospinal fluid, which is not good, right? Not good. So C-spine precautions, if they aren't already in C-spine, but C-spine precautions and airway breathing management. Okay, you may have to breathe for those patients. You probably have to suction for those patients, to keep their airway clear. But definitely, you've got some work to do on that patient. Okay, the basilar skull fracture, the mechanism was pretty intense, and so their body went through a lot of damage. Okay, so raccoon's eyes, periorbital ecchymosis, battle signs, and the halo test. Okay, so the name of the technique used to determine the presence of CSF fluid, that's the halo test. So now let's talk about epidural bleeds versus subdural bleeds. Okay, so there's a couple differences here. First off, you'll need to know that this is a bleed within the head. Okay, but it's not within the brain. It's not a hemorrhagic stroke. This is actually a bleed in those meninges. Okay, and if you guys remember from Mod 2, when we talked about meningitis, we're talking about the meninges. Those are the connective tissues. Sorry, I'm trying to talk and type at the same time. Those are the connective tissues that are around and surrounding the brain and the spinal cord, right? So if you look at this, here's your scalp, right? So here's your skin. Here's your skull, which is the cranium. Then you have the dura mater, which is this blue. Dura means big. Mother is like big mother, right? You have the arachnoid space in between the dura mater, and then you have the pia mater, which is small mother, and it actually lays on the surface of the skin. So the pia mater is the layer that actually lays upon the surface of the skin. You can see how it kind of goes in the little crevices and all that kind of stuff. Then you have the arachnoid space. Then you have the larger dura mater, and then your skull. So those three layers, those are your meninges, okay? And they cover both the brain and the spinal cord. And when we have an epidural bleed versus a subdural bleed, this is where it happens. So it is a bleed inside the head, but it's not a bleed inside the brain, okay? Super important for you guys to remember this. So obviously it's going to happen from some kind of trauma, okay? So epidural versus subdural. And we'll just take a look at this, and hopefully this will. There we go. I don't think I can get this any bigger. So let's talk about the epidural hematoma first. Epidural, so epi means outermost. So this is going to be outside of the dura mater, okay? So inside the skull, but outside the meninges and outside the dura mater, okay? An epidural hematoma is a bleed that will have a rapid onset of symptoms, and has a rapid onset. We'll talk about the symptoms in a minute, but it has a rapid onset because it's an arterial bleed. And if you guys remember from the different types of bleeding, arterial bleeding has the, is that pulsing one, right? It's that spurting, pulsing one, because it's the arteries, it's that oxygenated blood, and it's being pumped from the left ventricle, right? Versus a bleed from a vein. You can still bleed a lot from a vein, but it's not going to be pulsing and spurting. So it's not going to be as fast. So an epidural bleed occurs because most of the time there is a skull fracture that occurs with it. So it says occurs suddenly related to head trauma and skull fracture. And what happens is this meningeal artery that's in here, this meningeal artery, middle meningeal artery that's in there, that is what is damaged. And when that tears and it's bleeding, it's an arterial bleed, right? And so the blood accumulates rapidly outside the surface of the brain. And when that occurs, your patient's symptoms will be a rapid onset. So, unconsciousness will happen pretty soon, like within minutes of the head injury. So here's severe headache, nausea, vomiting, confusion, changes with pupils, slurred speech. And unconsciousness, just, add that in there, unconsciousness, okay? It says the treatment is a burr hole. Well, guess what? We don't do that in EMS, right? We don't. We recognize it and manage the ABCs and get them to the hospital, okay? And again, your patient is also going to have Cushing's triad, okay? So those three things, right? The widening pulse pressures where the systolic blood pressure is increasing. We're going to have bradycardia and irregular respirations with the mechanism of the blow to the head, right? The traumatic brain injury, the head injury, unconsciousness, unresponsiveness, preceded by a brief moment of nausea, vomiting, confusion, dizziness, that kind of stuff, okay? Now, a subdural hematoma, subdural, this is below the dura mater, okay? So the accumulation of blood that occurs here is beneath the dura mater, but it's still outside of the brain. Again, it is not within the brain. It's more kind of like in that arachnoid space, beneath the dura mater, but outside of the pia mater and outside of the brain, okay? This is a slow onset of symptoms because it is a bleed from a vein. Okay, most likely there's not a skull fracture. Okay, it's still a pretty intense blow to the head, but it doesn't always cause a skull fracture. And the bleed is not from an artery. The bleed is from a vein. And because the bleed is from a vein, it has a slower accumulation of blood. And because of that slower accumulation of blood, your symptoms will come on at a slower pace. Okay, so they're going to develop gradually over time. And this time could be like a day or two versus immediately following the injury. Okay, Symptoms would be fluctuating level of consciousness. Oh, excuse me. My apologies. So symptoms could be fluctuating level of consciousness, slurred speech, complaining of headaches, confusion. Maybe, they're just not acting like themselves. And this, but again, this is going to happen later. So if you can kind of think of a patient who maybe they, I don't know, maybe they fell and hit their head, or maybe they had a midfield collision at a sporting event, like a soccer or something like that, where they don't have a helmet and they had a head injury. Okay. Maybe they don't feel good. They're a little bit, their head's hurting and stuff like that. They sit out for the rest of the game. They go home the next day, or they go home the next day. They're kind of having a headache, and then maybe that later that night or later the following day, they're really going to start having these changes, or these symptoms appear. Okay, because that bleed has slowly been occurring over the last however so many hours, right? An epidural hematoma, it could be the same exact mechanism, but most likely a skull fracture. It's an arterial bleed, so it's a rapid onset. So that midfield collision, you're going to get there, and the patient's going to have be complaining of a really bad headache, and I don't feel good, and all of a sudden they're going to lose consciousness. Okay, they may have a brief return of consciousness, but they're going to lose it again, and they're going to be out because it's such a rapid accumulation of blood. So that's the difference between the two. But keep in mind, they're also going to have Cushing's triad. Okay. Now, if you get a chance to, when you're on your clinicals, if you get a chance to go into the CT room and stand behind the monitors while they're taking a CT of a patient, then this is what an epidural bleed looks like. It has this kind of convex shape because, remember, it's outside of the dura mater, and it just accumulates, and it's pushing the brain, right? But a subdural is inside the dura mater, outside the surface of the brain. It has this concave kind of crescent moon shape. Both of them are going to cause Cushing's triad. Both of them are going to displace the brain. Okay, if you look at this, this is the midline of the brain. You see how it's kind of over? It should be straight up and down. Okay, but it's going to displace the brain, cause symptoms. Whoops, sorry. And cause problems. Okay. If you get a chance. So make sure you know the difference between epidural and subdural, how it happens, and why it happens. Okay. Epidural is outside that dura mater, arterial bleed with a skull fracture, rapid onset. Subdural, inside the dura mater, but still outside the brain, from a vein, and a slow onset of symptoms. Okay, make sure you know the difference. Okay, so remember when I was talking to you guys about events leading up to, your sample history, and we always say, well, what were you doing when this, when your pain started, or what were you doing when this started? With a subdural bleed, you may have to dig back a little bit. It's not necessarily an immediate thing, right? Epidural bleed was, oh man, we were just playing around, and they smacked their head on the side of the pool, and just a couple, just 10 minutes ago, and now they're like this. Or I don't know, I was just sitting here, and my head was really hurting, and my head's been hurting, for about a day or two. Oh, well, what has happened in the last couple of days? You kind of have to build back, right? So events leading up to don't always have to be immediately preceding their symptoms start, but sometimes you have to kind of dig back a little bit more into the history. Okay, so shifting gears to environmental emergencies. Okay, hyperthermia versus hypothermia. This is going to be your heat and your cold emergencies. I believe this is chapter 33, I want to say. but it is definitely due on this module. Okay. So let me turn my phone on. All right. So when you're talking about hypothermia is, you can think of it as the heat loss exceeds your heat gain. So you're losing too much heat. You're not able to keep up with the heat loss. Okay. This is where your core temperature is going to be falling and dropping below certain levels. And we'll kind of talk about, certain levels and different signs and symptoms that you might be able to see. But basically, your body's not able to regulate its own temperature. It's not able to produce body heat, and all kinds of things occur, right? And obviously, the colder we get, the worse it is. If there is water involved, then your symptoms of hypothermia are going to be quicker, okay? Because we're going to lose heat more rapidly if there's water involved. Okay, so let me pull up your chapter 33. There it is. If you're ever wondering about, checking a patient's temperature and stuff like that, then feel their belly. I know that sounds weird, but if we're talking about core temps, then feel their belly. Put the back of your hand, an ungloved hand, against the patient's abdomen to kind of feel their core temp. And if they're cold there, then their core temp is low, right? So if you want to look in chapter 33, there's a table 33-1. This is your basic characteristics of systemic hypothermia. And systemic, remember, means body-wide, right? You have mild, moderate, and severe symptoms. So your mild symptoms are going to be when your core temperature is, in between 95 to 93 degrees Fahrenheit. This is your core temp. And remember, we should be 98.6, right? Textbook perfect is 98.6. But if we drop just a couple degrees, then you're going to start to see signs and symptoms of hypothermia. And the first ones are your skin is going to be cool and pale. The mental status, your patient's still going to be alert, but they're going to be shivering. Okay, and they're going to have poor muscle coordination and tachycardia and tachypnea. Okay, so heart rate's going to increase, respiratory rate's going to increase. And when I talk about that poor muscle coordination, I just want you to think about the last time that you were outside when it was cold. Okay, and maybe you didn't have gloves on or something like that, right? And your hands and your fingers got really cold, and like you're trying to get your phone out. Maybe you're trying to type a message to your friend or family member or something, and your fingers are just like moving really slowly, right? Well, that's hypothermia right there in your extremities. Okay, so that's that poor muscle coordination. But you're still alert. You're shivering because shivering is your body's attempt to produce heat, right? So your body is still trying to regulate its own temperature and keep heat in, but that's going to be more on your mild side, okay? Rapid breathing, constricted blood vessels, tachycardia, things like that. How do we treat that? First thing is you got to take your patient in from the cold environment. You have to get them out of that cold environment. And then just our goal is to prevent further heat loss. Okay, so get them away from the cold, and then we kind of passively rewarm them. Okay, the first step of passively rewarming them is getting them out of the cold, and then just, you can put blankets on them and stuff like that, but you're trying to keep them from losing further heat. Moderate symptoms are going to be more related to, and there's different levels of moderate, but moderate symptoms is going to be, when your core temperature gets down to like 89 degrees, that one, we're definitely going to have some loss of coordination, stiffness in our muscles, confusion, right? The mental status is not going to be good anymore, right? We're going to have confusion, sleepiness, like I said, muscle rigidity and muscle stiffness, and your patient's no longer going to be shivering. because at that point, already at that point, the body's not able to regulate its own or help with the regulation of temperature, right? Okay. Your skin is going to have kind of a cold, waxy appearance, puffy face, and your respirations and your pulse are now slow. Okay, so we went from mild, which was tachycardia and tachypnea and shivering, to a couple more degrees, below that, to about 89 degrees, because we were at, 93, 94. Now we're at 89, 90. And we're now cold and waxy, confused with no shivering, bradycardia, and bradypnea. Go a little further, okay, and now your patient absolutely is, they're unconscious, they're unresponsive, okay? There's diminished reflexes. Overall, pupils are dilated, muscles are rigid. You definitely have bradypnea with that slow breathing, hypotension, bradycardia, okay? This is where our core temp is down into the low 80s, okay? So not only are we trying to prevent further heat loss, but when your patient is in that form, now we're trying to actively rewarm them. Okay. If they have any wet clothing, you got to take it off, because that wet clothing is going to increase, like exponentially increase the loss of heat. Okay. So get that wet clothing off of them and then actively rewarm them. We're going to add heat packs to their axilla and their groin, turn up the heater in the back of the patient compartment. Right. And if you're able to get ALS on your scene, maybe they can introduce warm IV fluids. The point at that point is to get heat to the patient's core, right? Because their core temp is so low. Now, we definitely want to be gentle when we're handling our hypothermic patients. We don't want to cause any pain or further injury to the skin, because the skin is going to be, the skin hasn't had circulation, or proper circulation to it for a while, and so it can break down pretty easily. And the heart is very, very irritated, so you want to be careful with your patient, because if you handle them too roughly, you'll actually send them into ventricular fibrillation, which is, of course, where the heart isn't beating appropriately, and now you're doing compressions. Okay. Now, if your patient goes even further and they're in what we call severe hypothermia, where their core temp is less than 80 degrees, then they're basically gonna be in cardiac arrest. They're gonna look like they are dead. Okay, cardiac arrest, unresponsiveness, barely detectable, if any, vitals at all. Cyanosis, fixed and dilated pupils, things like that. And of course, not only are we providing CPR and resuscitative measures, but we're also trying to rewarm our patient while we're doing compressions and airway management. Okay. So, cold, it doesn't have, I've lived in Texas all my life. It can get cold around here. It definitely can. We definitely have our winters where it's cold, and I've been on the box where, a little lady went outside to check her mail, slipped on the ice, and was outside for a while we got there, and we're trying to package her up and everything and get her into the back. And then we actually, have to rewarm ourselves in the back of the ambulance just so we can move our fingers appropriately to start helping her, So those are little things you have to think about, okay? Not only will the cold affect your patient, but the cold will affect you, right? So be careful in handling your patient, but get them out of the cold as soon as possible. There's a saying that says your patient is not dead until they are warm and dead. Okay. And so if you do find a patient who is hypothermic and they're in apparent cardiac arrest, then you work them until we get their core temps back. And then decisions are made by physicians, on whether or not to call the resuscitation and terminate that resuscitation. But your patient is not dead until they are warm and dead. Okay. All right. Moving to hyperthermia. So hyperthermia is your heat emergencies. And guess what? Your very first treatment of your heat emergencies is to get them out of the heat, same as if it was to get them out of the cold, right? But heat has 3 very distinct phases to it. And again, living in Texas, I'm sure each of you guys have experienced at least one of these, okay? Your first is your heat cramps. Your second is your heat exhaustion. And then your third is your heat stroke. Now, I hope none of you guys have experienced your heat stroke because, of course, that's the most severe. But it's really easy to be outside and doing activities and things like that, and not really kind of keeping up with the fact that maybe you're getting a little hotter than you should be, and you start having some of these symptoms. So hyperthermia, the textbook definition of hyperthermia, is where the heat gained exceeds your heat loss, right? So I'm not able to get rid of the heat from my body as fast as I'm taking it in. So my body, heats up and gets that hyperthermia. Okay. Climate, exercise, strenuous activity, extremes of age, lack of acclimation, all of those things can be factors in hyperthermia. You ever have someone who just moved to Texas and they're like, man, I cannot take this heat. Well, you kind of have to get used to it. But then on top of that, here in Texas, we have that humidity, and the humidity just like the cold, the wet clothing and hypothermia, the humidity and hyperthermia, again, exponentially increases the effects of hyperthermia because it's that just suffocating heat, right? Okay, so let's talk about it. Heat cramps. This is your first phase. And this is where you basically have muscle spasms from electrolyte imbalances, okay? So you've been outside for a little bit, you're sweating a lot, and sweating is good because sweating is your body's way to regulate body temperature, right? Just like shivering in hypothermia, and shivering, we're trying to generate heat. When you sweat, you're trying to cool yourself down, right? That's your body's way of trying to cool itself down. So you've been sweating a lot, and because of that, you're sweating out fluids and electrolytes. And if you don't replenish those with water and Powerade and Gatorade and all that stuff, that's out there, all those aids that are out there, then you can get an electrolyte imbalance, and your muscles will start to seize up and spasm. And it's really painful. Most of the time, it's your large muscle groups that are affected first. And they're just spasming and twitching, and it's painful, and your patient, they cannot make it stop. Okay. They'll have also be complaining of a headache. Their skin will be kind of that flushed, the warm, but still wet and diaphoretic because they're able to sweat. Now, heat exhaustion is one step further, and that's when that electrolyte imbalance has now worsened because, again, you've lost more. And dehydration is now developing. You've got, again, the loss of water and the electrolytes from that heavy sweating. You're losing too much, and you're starting to get volume problems. Okay. You'll have dizziness, weakness, dizziness on standing, weakness. You may have a syncopal episode, right? A syncopal episode is when you pass out, right? It's that brief loss of consciousness, you pass out. You're going to be thirsty. Your tongue's going to feel dry, and your skin is going to be cold and clammy, maybe ashen in color, but you're still sweating. Okay, so you're in hypovolemic shock with this, basically. Okay, and remember, phase 1, tachycardia, normal blood pressure. Phase 2, decompensated tachycardia and hypotension. So that dehydration. And I'm sure, think about it this way. How many times have you guys, and I hope it hasn't been a lot, and I hope, if you haven't experienced this, I hope you never do. But if you've ever been outside a little bit longer, maybe you're, trying to intake your fluids and things like that, but you just don't, you're not drinking enough. And then all of a sudden you're like, man, and it just hits you out of nowhere. You're like, man, I don't feel good and I need to sit down, and you're getting all dizzy and everything. You have to sit in the shade. We try to cool you off. Okay. So get them out of the heat, try to cool them off, right? Get cold packs on their neck, give them something cool to drink. This is probably the only time that we actually give something by mouth, to fluids by mouth as a treatment, because we're trying to cool them off in their core, cool them off from the inside out, right? And you've got your cold packs. But that's heat exhaustion. The next one is heat stroke. This is your last one, heat stroke. This is the most serious form of your heat emergencies. And this is when your body's thermoregulation fails. So your body cannot cool itself. So your patient will not be sweating. Previously, in your heat cramps, you're going to have that flushed, warm, but wet diaphoretic skin. In heat exhaustion, they're going to be cold and clammy and ashen and pale, right? But they're still wet. They're still diaphoretic, but they're cool because they're, vasoconstricted and fluid depleted, right? Heat stroke, unfortunately, now they have hot and dry, flushed skin because they can no longer sweat. This is where the body temps are really high. They're dangerously high, and they're actually going to damage brain cells, okay? Your patient's going to have confusion, altered mental status, experience seizures. They may be completely unresponsive, okay? But this is where that body temperature gets really high. And like I said before, your body cannot thermoregulate anymore. Okay. Oh, let's see. See if I can get you No, that's fine. Okay. So basic treatment for your heat emergencies: get them out of the heat, cool them off. Sometimes it's something as simple as taking their shoes and socks off, or if they have excess clothing, kind of helping them out of some of their layers. If they're in that heat exhaustion, then we now need to be actively cooling them and applying cold packs and giving them cool water, right? Heat stroke, on the other hand, we're not giving them anything by mouth because they're confused, they're altered, and they're kind of past that point. But we're trying to actively cool them and get them to the hospital. Okay. So moving on to burns. And burns, we have, I guess we'll talk about, the different degrees in just a moment. But one of the things that we need to do with burns not only is know how severe the burn is, but we also need to estimate the amount of body, percentage of body that is affected by that burn. We call it TBSA, total body surface area, that is affected. Okay, it's a percentage. An easy way to do this is we use the rule of nines. Okay, and the rule of nines, if you look in your book, and let's see, burns are in chapter 27. Yeah, chapter 27 with your soft tissue injuries. If you look at figure 27-19, this is going to go over your rule of nines. Like I said, it's a quick way to estimate the amount of surface area that's burned. And basically, it divides the body into different sections. And the different sections are awarded a certain percentage. And it's by nines. Okay, so the rule of nines. The head, the chest, and the back. The chest is the thoracic and the abdominal cavity. So the front or whole anterior chest and the whole posterior back, upper and lower back, each arm, each leg, and then the groin. That's basically how it's separated, okay? And then we're just going to go ahead and pull up a picture here so you can look at it here. Rule of nines. Okay. Okay. What is this one? Is this the one that I like? This is the one that I like. Okay. So you've got your adult and you've got your infant. Okay. So on your exam review, the first thing that it says is head. Well, if you notice, the head is different between the adult and the infant, because keep in mind the head is proportionately larger for the infant than it is for the adult. So for an adult, the head is 9%. For an infant, the head is 18. The entire front and back is 18. Front and back on an adult is 9. Okay. On the chest, the entire front, chest and abdomen, right? So the anterior torso, it's probably the easier way, is 18%. Same for a kid and an infant, 18% on the anterior torso. The posterior torso on the back is also 18% for both. Okay. Each arm is 9%. That's the whole thing, front and back. Each arm is 9%, okay, on both the adult and the child. The legs on an adult, the whole leg is 18%. The whole left leg is 18%. The whole right leg is 18%. But on a child, those legs are proportionately smaller. Okay, so they're normally like 13.5 up to 14% per leg. And then the groin is 1%. Okay, it's always 1%. It's a very important 1% though, because if there's any burn to the groin, that is an automatic transport to a burn center. Automatic transport to a burn center. It doesn't matter how, who, what, when, where, or how. If it's a burn to the groin, they're going to a trauma burn center. Okay. So this is really important because it's a way for us to quickly estimate. Because when we're doing our hospital reports and we say, yes, this patient is suffering from a second-degree burn, they need to know how much of the body was affected. And so that's where this rule of nines comes from. Okay, you can say approximately, 28%, right? Or 27% or 18% or whatever it is. There is also something called the rule of palms. Okay, and the rule of palms is where we normally will use this for smaller burns. Okay, smaller burns. And basically you take the palm of the patient, not your palm, but this much, that's going to be approximately 1% of their body. And so you use that patient's palm to estimate the body surface area that's been burned. Okay, just the palm, not the fingers, just the palm. Okay, and we normally, like I said, we normally use that for our smaller areas. If you're looking more like this whole extremity or this area of the back or this and that, use your rule of nines. If we're talking about smaller areas, then use that rule of palms. Okay. So going back to your review, the different burns themselves. You have your first degree, your second degree, and your third degree. Now, your first degree is what we call a superficial burn. And practically everybody has had everybody in our class has had a first degree burn. I'm willing to bet that everybody has had a first degree burn because this is a sunburn. Okay. A first degree burn is the most superficial, and it only involves the epidermis, which is the most outer layer or the top layer of the skin, right? What we'll see that the skin is going to turn red and it's painful, but there are no blisters because it's only on the outermost surface of the skin. Now, your second degree, which is what we call the partial thickness, some of you may have had this also, right? Because this is where you have blisters. The burn is a little bit deeper into the dermis. And because it's deeper and it involves more layers and more portions of the dermis, then you're going to see more injury, right? So it doesn't destroy the entire thickness of the skin, which we'll talk about as far as third degree, but it is deeper than your first degree. And so typically the skin is going to be moist, mottled, and remember that mottled is that kind of whitish, reddish, color, right? Painful, with blisters. Okay, with blisters. And then your third degree, which is what we call our full thickness burns. These are this burn is going to extend through all the layers of the skin, and it may go into subcutaneous tissue, adipose tissue. Adipose tissue is your fat. Okay. Muscles, it may go into bones. It's deep. It's a deep burn. Okay. The burned area itself, it's not going to be red. It may be kind of a white, leathery color, kind of a white, dry, leathery look to it. Or it could be a really dark, kind of charred look. Okay. And I'm trying to find it on here. Of course, it's the next one. There it is. Anyway. Your third degree burn, because it extends through all the layers of the skin and goes deeper than that, then it has it's affected your nerves, your nerves and your nerve endings. It's burnt through those. So the areas of your third degree is painless. You're not. It's not gonna. There's no pain in that area. Okay. But so it's going to be white and leathery looking, white, dry. It's terrible, but it's the skin is cooked in that area. Okay, it's cooked. It's not moist. It's dry. It's white and leathery or charred and dark color, and it's painless. Now, on the peripheries of that third degree burn, where we're kind of transitioning into normal skin that is not burnt, the peripheries of that burn will be painful. But the area, like the center and the area of the third degree burn itself, will not be. So if I was to show you, no, I want to actually, I don't know. I look at these all the time, but I don't know which picture I want to show you. But this, we'll just go with this, kind of the cartoon illustration, which is totally fine. So in the center right here, this is where it's going to be painless. Okay. But as we approach normal skin that's not burnt, it's going to be painful on the peripheries, because this right here is only second and first degree, right? So it's going to be painful out here, but in the center where we have that third degree, that's where it's going to be painless. And it's either going to be that dark charred look or kind of a white, leathery, dry look. Okay. Second degree, we've got those blisters, right? It's red, it's white, it's mottled, it's moist, it's painful with blisters. And then the first degree is that superficial, most outer layer of the skin, red, pink, and painful, no blisters. Okay, no blisters. Let's see what this is. Okay, this is really terrible, but we've definitely got some pretty deep burns in here. Looks like it actually has. Okay, never mind. That's YouTube hand burn. Here we go. Okay, so you see how it's kind of white. Okay. Now it may not be painful here, but it is on the peripheries where we're going back to the normal skin right here. Okay, I think you guys get the picture. So when you have a patient who has a burn and you're given a report to the hospital, you have to tell them what kind of burn it is and where it is and how much body surface area is affected. And that's why it's so important to know the rule of nines and possibly, use that rule of palms if you need to. Okay. Now, how do we treat burns? Well, there's a couple things that we can do. The first thing, very similar to those environmental emergencies, the cool and the heat, where we get them away from the source. It's the same thing, right? You got to get them away from the source of burning first. So if they're still, maybe they're unconscious and they fell against a heat source or something, and they can't move away from it. So our first thing is to get them away from it, right? That's where you're going to have those third degree burns where they've had a long amount of contact with something, right? So as far as the treatment, though, we can use wet dressings, kind of moist, wet, and sterile dressings. But you want to use that on your minor burns, like your first and second degree burns, and in smaller areas. Because remember when we were talking about our hypothermic emergencies and how wet clothing can accelerate the heat loss? Then I don't want to do that with my burn patients, right? I don't want to, if they have third degree burns over large surface of their body, or really if they have third degree over more than 10% of their body surface area, then I do not want to use a wet dressing, because that will accelerate their heat loss and make the patient worse. So if it's a small area, less than 10%, first, second degree, I can use moist dressings if it's a larger area, more than 10%. And, my third degree, then I use dry dressings. Okay. I want to keep them, I want to avoid hypothermia. Okay. Now, some of the things that, before we get off of burns here, one of the things that, another thing that I want to do, not just get them away from the source of burning, but I want to prevent that hypothermia. Okay, so there's burn blankets, that you can use to put on your patient, because the skin is really what has been damaged here, and the skin is our first barrier against the outside environment, right? It's our first barrier against germs and all that kind of stuff, right? But it also helps to temperature regulate. So if our skin is damaged, then we can no longer regulate, our bodies can no longer regulate temperature by itself. So we can lose a lot of heat. And you don't want hypothermia in your trauma patients, okay? Hypothermia is a deadly factor in any kind of trauma patient, not just burns, okay? But burns, I definitely want to prevent that hypothermia. So put a burn blanket on them. And then watch for airway swelling, okay? Because you can have burns on the outside of your skin, but you can also have inhalation burns. What if you had a patient who has singed nose hairs, or they've got what is it I'm talking about? Maybe like some of their, like you open their mouth and you look in their mouth and they've got soot in their mouth, right? So, this guy, he's got soot in here, and some of these nose hairs are singed. He's got soot right here. It's kind of hard to see his mouth, but he's got soot, so it's black. If this person had a mustache or a beard, and some of that looked like it was singed off, or like I said, their eyebrows looked like it was singed. Wow, that's really terrible. Of course, we talk about this, inhalation injuries and intubating and all that kind of stuff in paramedic school and advanced EMT, but that definitely is a problem, right? Because if that heat, when that heat is applied, it's going to cause swelling. Okay, it causes swelling. It makes your cells lose volume into the interstitial spaces, which is the spaces in between their cells, and it causes what we call third spacing, where there's swelling. And if there's any heat that went inside your patient, down their trachea and into their lungs and all that kind of stuff, then they're going to be swelling in there, and they're it's very similar to like anaphylaxis, right? Upper airway swelling. They can have stridor. Right, they can have coughing, stridor, signs of inhalation injuries from the soot on their face, or the singed facial hair and nose hairs and things like that. Let's see. Coughing, wheezing, nausea, chest pain, of course, if the heat went all the way down in here. Okay. If any of that is a problem, then that's a rapid transport to the hospital, okay? Because unfortunately, there's not anything we can do to keep it from swelling. We need to get them somewhere before their airway completely swells up. So if you look at this one, look at that, okay? So this is actually their vocal cords, okay? This is going into their trachea. This is their vocal cords, and nice and easy and nice and open. But this is swollen, and they have this tiny opening for them to breathe. So that's where you're going to hear your stridor, because you have this tiny, tiny opening. And if this completely swells up and closes, it doesn't matter if you're bagging your patient or not. There is no airway. There's no pathway for the air, So those inhalation injuries are high priority patients, very, very high priority patients. Okay, just something to think about. So I'm trying to prevent hypothermia because my skin is damaged and it cannot, it cannot thermoregulate. So I have to help them with heat loss. I want to watch for airway swelling and transport rapidly if there's any inhalation injuries. And I want to watch for that shock. Okay. And just because they're not losing fluid out of their body, it doesn't mean that they're not going to go into shock. And that's what this burn patient is experiencing with that third spacing, when they're losing fluid from proper places in their body because of the swelling that's occurring. Okay. So the fluid is leaving the proper places and is going somewhere else. And so it's kind of what we call a relative hypovolemia. Okay. It's a relative hypovolemia. It's not a true hypovolemia. The volume isn't leaving their body. It's just going to different places. So you got to watch for those vitals and things like that. Am I worried about infection in a burn patient? Not when I'm on scene of the incident. Okay, because infection is something that will happen at a later time. Will it happen? Yes. Am I worried about it as a pre-hospital injury and management? No. I'm worried more about their airway, their heat loss, getting them away from the source of burning, and I'm worried about fluid levels and things like that. I'm not worried about infection when you're on the scene of the call. Okay. Okay. All right. When we have an impaled object. Okay, so when we have an impaled object anywhere, then there's only 2 times that we can remove it. And that would be if it's impeding or keeping us from managing a patient's airway, or it's keeping us from doing chest compressions. Okay, if neither of those 2 cases is present, then that object that's stuck in your patient or impaled in your patient, it stays in place, and I'm going to secure it in place. Okay. Okay. So let me see here. Well, that's really it. I mean, think of it this way. If you have a patient who is stabbed in the chest and they are pulseless, apneic, and unresponsive, well, and that knife is right in the way of me doing compressions, well, I'm going to have to remove it, right? If it's in their back, anywhere in their back, upper, lower, torso, doesn't matter, anywhere in their back, and they're pulseless, apneic, and unconscious, then I'm going to have to remove it and place an occlusive dressing on it, right? Because I have a penetrating injury, an open chest wall injury. So place that occlusive dressing on it, turn them over, and do my compressions, right? If I have any kind of impaled object in their mouth, or angled up into their jaw in their mouth or anything like that, then I may have to remove it if it's keeping me from doing airway management. But any of those other things, or anything that is not affecting that, then it stays in place, and I need to secure it. Okay. And when we talk about securing impaled objects, then the easiest way is to put some bulky dressings next to it on both sides of it. Let me see if I can find you a good picture of this. Yeah, I don't really like that. Here we go. I like this one. That right there. Okay. So you've got bulky dressings on each side. All right. This looks like this is a knife that's going into their arm. So you put bulky dressings, whether it's a roll of Curlex or whatever it is that you want to use, but put it on both sides, and then take your other Curlex and wrap it to keep it in place, right? Because I just don't want to move this. Don't wrap it so tight that we lose pulses and motor and sensation to distal, right? Don't wrap it too tight, but you need to secure it to make sure it doesn't move, right? Now, if you maybe have an impaled object in the neck, let me see if I can find. This is actually pretty good here. It kind of shows somebody made what it's called a little donut, where they basically took a roll of Curlex and they just, it's kind of time consuming, but they just rolled it in upon itself over and over and over until it formed a donut. An easier way to do it is just take 2 bulky dressings, one on each side, and then wrap it. Okay, but you got to secure whatever it is in place. Let me see if I can see this. if it's going to show you. If not, I know we're going to go over it in class. We'll go over it in class. Okay. But impaled objects, if they are inhibiting airway or keeping us from doing compressions, they have to come out. If it's not, then they stay in place and we secure it. Super simple, okay? Super simple. Number 10, what's the difference between an open pneumothorax versus a closed pneumothorax? What's their treatment? What happens if the pressure continues to build up? So we talked about this at the beginning of the review. Remember, your open pneumothorax is where you have a hole in the chest wall, and this can be anterior or posterior, but it's a hole in the thoracic wall, and so it's open. Our treatment of that is to place a gloved hand on top of it and then place an occlusive dressing on it to make sure that it can vent if air builds up in that pleural space. A closed pneumothorax is where you don't have a hole in the thoracic cavity. There is no hole, but there's damage to the lung, and it is accumulating. It's starting to fill that pleural space and collapse that lung. What happens if the pressure continues to build? Either one of these, an open or a closed, or even a spontaneous pneumo, either one of those can develop into a tension pneumo if the air continues to accumulate, and that tension pneumo is going to cause obstructive shock and other problems, right? You're going to have diminished and absent breath sounds on the affected side, continued shortness of breath, and your vitals are going to, show developing hypotension and things like that. If you have an open pneumothorax with that occlusive dressing, check that occlusive dressing and make sure that it hasn't clogged off or stopped up somehow. If it has, then you may have to replace it with a different one, or you may have to vent it or burp it yourself to allow the air that's accumulated inside to release. So the tension and the pressure is released. Okay. What are the differences in a dressing versus a bandage? So a dressing is going to be the sterile stuff, or gauze or things that you place against the patient's skin up against the actual injury, and then a bandage is what keeps the dressing in place. Okay, so the dressing is normally like the sterile 4x4s or the sterile trauma pads and things that we put on, and then the bandage is the Kerlix that we use to wrap around to keep the dressing in place. What's the following functions of each? So we've got tendons and ligaments and cartilage and all that good stuff. Okay, so different things. They do different things. Let me see here. I'm trying to find my notes. Where are they? So your tendon is the connective tissue. It's a fibrous connective tissue that attaches muscle to bone. Okay, so it's going to, this is what, attaches basically your skeletal muscle to the bones, right? And so when you move your joints and all that kind of stuff, it's attached to your skeleton. The tendon will attach to the bone, and then when it goes into the muscle, it kind of disappears up into that muscle and goes into that muscle. But tendon attaches muscle to bone. Ligaments attach bone to bone. You will find your ligaments in your joints, and they support and strengthen that joint. Okay, so so those are different. Cartilage. Cartilage is going to be that smooth connective tissue that forms the support structure of your skeletal system, provides cushioning between the bones. Okay. And then fascia is a fiber-like connective tissue that covers a lot of different things in our body: arteries, veins, tendons, ligaments. Okay, fascia is, if you've ever gone to like a cadaver lab, or if you've ever had A&P and you had a lab where you were dissecting something, you have that connective tissue that you have to get through to get to the muscle, or that connective tissue that's surrounding the muscle, then that's fascia. Okay. And it's everywhere in our body. So just kind of know the difference between the two, or the four different things here. Specifically, tendon is muscle to bone, ligament is bone to bone, things like that. Different treatment for open fracture versus closed fracture. Where an open fracture is where the bone has protruded through the skin, okay? And the bone might still be through the skin, or it may have gone back in. But either way, I have the skin above the fracture site is damaged and broken, okay? So the way I would treat that is I would need to put a sterile dressing over it and then splint, right? I need to still splint that fracture, but I need to go ahead and cover that open damaged skin. Versus a closed fracture, that's where the skin is not damaged. The bone might be broken underneath the surface, but the skin is still intact. So I'm not having to worry about dressings or bandagings or anything like that. I'm strictly worried about splinting and immobilizing and checking my pulse motor sensation and things like that, right? Open fracture, of course, I may have to deal with uncontrolled bleeding depending upon how bad the tissue damage is at the site. How do we splint? So we've gone over splinting quite a bit in class up to this point. Remember, there are two different things that we do. We splint joints and we splint long bones, right? So when you're splinting that long bone, splinting long bone. Okay, so let's just say, this is a great picture. All right, so this guy has, actually, it looks like this is a knee injury. Okay, so we'll go with this. This is a joint. Okay, so we'll talk about joints. So let's say this guy's knee is sprained, stretched, something like that. Maybe one of the ligaments in here, right? The ligaments in the knee attaching the bone to the bone, the tibia to the the tibia to the femur or something like that, right? Something in here is hurt and we're trying to reduce the movement of that joint. Okay, so I will take the long bone above the joint and the long bone below, and I will secure those in order to make sure that that joint's movement, natural movement, doesn't occur, right? If your patient, and we'll just use the same guy right here, if we had a long bone fracture or a long bone injury, okay, let's say that his radius, because his radius is here by his thumb, right? His radius is broken. Let's say it's fractured right here. Then I would want to immobilize his joints above and below the site because I have two pieces of bone that are trying to move in here, and I want to make sure that the ends of those bones, don't move to keep it from having any more injury to the tissues around it. Okay, so if it's a joint, then I want to immobilize and secure the bones above and below that joint to keep the joint from doing its normal range of motion. And if it's a long bone, then I want to secure the joints above and below the long bone to make sure that those pieces of that bone, again, don't move and shift and all that kind of stuff. What do I check before and after? Pulse, motor, sensation. Always, always, always. Pulse, motor, sensation. Okay, before and after. When you guys are doing your skills checkoffs and stuff like that, when you guys are doing those skills checkoffs, then you will definitely need to tell your evaluator that you're checking pulse motor sensation before and after. Absolutely, got to do that. Okay, if you don't, then it's a failure criteria. Okay, if you don't have good pulses before, you normally have one chance to move or adjust the extremity to see if you can restore circulation before you splint it, okay? But we're not sitting there manipulating and all that kind of stuff. Even if the bone is like crazy backwards or something like that, I know in the academy class we were talking about, maybe it's an ankle fracture and the foot is backwards, if you have good pulses and good sensation, and then you splint as found, because the last thing you want to do, if you do have good pulses and good PMS, and you shift it back into its normal position and you've lost those pulses now you've made it worse, right? So check for PMS before and after. You definitely want to make sure you have pulse motor sensation after. And something that you might want to do is as you're splinting, as you're actually doing the process of splinting, just talk to your patient, you know, can you still feel me touching your fingers? Can you still wiggle your fingers for me? Are you feeling any numbness, you know, as you're going through? Because you don't want to do this beautiful splinting job and then they're like, yeah, my arm's been numb, like, you know, the whole time you've been doing this and now you can't feel anything, right? So you just wasted time. But check that pulse motor sensation before and after. Okay, number 15, talk about shock again. 15 and 16, talk